Good morning, everyone, and thank you for joining us for today's conversation on ensuring support services for youth with disabilities and special healthcare needs. I'm Lauren Wallens, the Strategic Operations and Communications Director at PolicyLab at Children's Hospital of Philadelphia, research center within CHOP's Research Institute. Today's event is the second in what will be a series of virtual conversations we're hosting this summer, centering around the impact of COVID-19 on children and families. I would encourage you to sign up for our newsletter or follow us on Twitter to get the latest details about these events. To start off today's conversation, I'm excited to introduce our moderator, Dr. Sophia Jan. Dr. Jan is the Division Chief of General Pediatrics at Cohen Children's Medical Center and a faculty scholar here at PolicyLab. She is also the Medical Director of the Health Homes Serving Children program for Northwell Health, care management program for pediatric Medicaid beneficiaries with complex medical or behavioral health needs. Dr. Jan, I'm going to kick it over to you to get us started.
Thanks, Lauren, for that wonderful introduction. Good morning, everyone. So clearly over the last several months, we've seen how the COVID-19 pandemic has really just devastated and significantly changed the lives of children and their families all across the country. And certainly we also know that these challenges are even more pronounced for children with special healthcare needs or disabilities. So for the purposes of today's panel, let's just define the population a little bit. For today, we're just going to use this definition that children with special healthcare needs or disabilities are those who are eligible for or are currently receiving early intervention services. They have an individualized education plan, an IEP, or a 504 plan. So thankfully, for COVID-19 in children, while all children are at risk, most children with COVID-19 have been asymptomatic or have had mild symptoms. But unfortunately, among those who've been admitted to hospitals, 25% have had chronic conditions. And among those admitted to U.S. And Canadian ICUs, pediatric ICUs, 40% have had chronic conditions, kind of recognizing sort of the impact that COVID-19 can have in terms of its complications on children with disabilities and special healthcare needs. And unfortunately, fear of COVID-19, of getting COVID-19 is causing parents, especially those who have children with special healthcare needs, to avoid public settings, including medical settings, school settings, having people come into their home. I wanted to use this opportunity to just show you, for a child with special healthcare needs, kind of all the people that they are dependent on. I'm going to share screen really briefly. Okay. So this is a care plan that was drawn by a family who has a child with medical complexity to really describe all the different services that their family is dependent on. And you can see in this kind of upper left corner all the school services that this child needs, right? They have physical therapy, occupational therapy, speech, their ABA therapists. The bus driver is really important, and their transportation to and from school. And then all of the developmental assessments that are required to be able to access and be eligible for these services. You look on the lower left corner in the blue, dark blue, and you see all the medical services that this child is dependent on, from primary care to subspecialty care, and in many cases to home nursing, home therapies. Then you look in the lower corner, I think that looks like teal to you, and at all the support people that this family is dependent on. Sometimes that's grandparents, neighbors, friends. It includes home services, as well as support groups. There's recreational activities that are dependent on different services to be able to provide. So you can just see just how complicated and how dependent a lot of these children are on all the social supports around them. So then what happened this past March when the COVID-19 pandemic started to hit? Suddenly, all of these services become less and less available as schools shut down, as we had families here in New York City where grandparents started getting sick and were hospitalized. Parents were hospitalized, and suddenly we had no one to take care of that child. It was devastating, right? Parents started to say, for those that weren't ill, they just huddled in their own homes, afraid to let therapists in, afraid to let home nursing in. In some cases, we had home nurses that actually did end up giving some of our children who were ventilator dependent coronavirus. And so, from this huge array of supports that a family is dependent on, suddenly it's just that child and their immediate parent. And so, what I think this shows us is that we need to try to figure out a way to reopen or at least provide equivalent services for these children. And while telemedicine and teleservices were able to substitute for some of these links in certain areas, certainly therapists tried to sort of provide some therapies over video links for those children that had access. Access was an issue. And so there was lots of problems over the last few weeks. So basically, this is why we are having this conversation. How can we really reopen schools and services safely for this population? And not just for this population, but also for their teachers, their aides, their therapists. And now we have the added wrinkle. When we thought that we had made headway on sort of dropping and making headway on controlling the virus, now we're seeing a resurgence. And this is taken from the New York Times this morning about we are now hit the highest number of new cases that we've ever hit in the United States. We have hotspots arising all over the country and not just in New York City anymore. So here we are today. And so let me unstop sharing. So the good thing is we are very excited and joined by a terrific panel of experts to kind of discuss today's topic. So a few reminders for those that are listening into today's presentation. All attendees' lines are going to be muted and your video is disabled throughout the event. But we're looking forward to a really robust discussion about these issues following the presentations. So if you want to submit a question, you can do so at any time during this event. Just use the Q&A feature located on the right-hand side of your platform. Dr. Marcia Gertz, our senior psychologist and faculty member at PolicyLab, she will be monitoring the questions and we'll turn to them after the presentations. So let me start by introducing our esteemed panel of speakers. So first up, we have Dr. Susan Cohen. She is professor of pediatrics in the Division of Infectious Diseases at the University of Pennsylvania School of Medicine and an attending physician at Children's Hospital of Philadelphia. Next, we have Carol Clancy, who serves as the Director of Special Education, welcome, for the Pennsylvania Department of Education. Her extensive background includes 25 years spearheading initiatives in the field of special education within her school districts. Also with us today is Rylan Rogers, hello, who is the Director of Public Policy of the Association of University Centers on Disabilities, where she works on federal policy and legislative issues that affect people with developmental disabilities and their families. Both as a parent and as a professional, Rylan has extensive expertise on topics including special education regulations, private and public health care financing, and family professional partnerships. And finally, we have Dr. Kate Wallace, it's a reunion, who is a faculty member at PolicyLab and attending at CHOP's Division of Developmental and Behavioral Pediatrics. She's an instructor of pediatrics at the University of Pennsylvania. Dr. Wallace's research focuses on improving the quality of identifying young children with developmental disorders and autism spectrum disorder. And with that, we'll start with Dr. Susan Cohen. And let me start off by having you give us an overview of COVID-19 and the risk for children.
always have to remember to unmute. So there we go. Hi, everybody. I think Sophia gave us a great picture of where we are. And when we scheduled this, I really hoped we would be having this conversation on a different national and local background, where we could all feel as though we were moving into a period of more safety and building on confidence that we had been gaining in our ability to control viral spread amongst everyone, obviously amongst children, but also amongst all of the critical adults that surround them. Sadly, that's not the case. Right now, what we're experiencing is a really rapid surge in cases. We're 80% up from where we were just 2 weeks ago. And I think this does show us one very important principle that underlies all of our discussions, which is our gains and our improvements are fragile at best. And that as we have this conversation, we really have to be committed to achieving two incredibly important aims. One are providing the educational, medical, and social needs that children with disabilities and special needs have. And the other is keeping all the people who are essential to providing those needs to that child safe and healthy so that that ongoing support can continue. A couple of things that we do know that are fall into the glass half full part of the equation, which are that children are not major drivers of coronavirus transmission. To our knowledge, with each contact with an adult, the child has about a 50% reduced risk of transmitting infection if they are infected. However, the other part of that is that children often have more total contacts than do adults. So we need to balance that bit of optimism with the reality that children move about and they have behaviors and developmentally appropriate behaviors that enhance the numbers of contacts and the risk of contacts. Some other things we know about children are that they can and will participate as best as able and as best as the adults around them in some of the COVID prevention activities. And I think these are becoming really essential parts of our broad civic education that we need to think about embedding as we embed instruction and other social education. And then I think the other piece that I can offer as an infectious disease doctor is that, like Sophia described, so many of the children who have gotten sick with coronavirus happen to fall in the group of children we're talking about. And so the risk of becoming more seriously ill with infection is higher than an otherwise healthy child. But their potential gains of having high quality, as close to their prior experience in educational, medical, and social supports is all that more important. So there's just more weight on both sides of the equation in terms of risks and benefits as we consider how to best return all children to school. And I think as a premise, I just want to make sure everyone understands I'm deeply committed to finding ways that children can get back into their best learning environment, and that is almost always needs to be supplemented with more than can be brought into a home. So with that, I'll turn it back to you, Sophia.
Thank you, Susan. Great. So let's turn to Carol to explore her perspective. So Carol, what are some of the primary considerations for health and safety as Pennsylvania's children with disabilities and special health care needs return to school?
Yes, thank you. First, on behalf of the Pennsylvania Department of Education, the Bureau of Special Education, and honestly all educators and school systems across the Commonwealth, we just wanted to thank the CHOP policy and this panel of experts for being willing to host this webinar to provide some additional support for our most vulnerable students as we plan to open school. So thank you very much. The first priority within the school system right now is certainly the safety and the welfare of all of our students and all of our staff. Concurrently, the schools are developing their wellness plans to meet the potential additional needs of staff and students, and to adjust our instructional plans to address the impact of the school closures. We certainly are using what we have learned from the closures to make plans for moving forward on how to enhance the equity of offerings or opportunities, but at the forefront of our minds right now within special education is how to plan to transition students with disabilities back to in-person services in the safest manner. Working with students with disabilities, it raises some unique concerns of the complexity of how to follow the health and safety guidelines for a population that may not be able to comply with the health and safety guidelines of the school system, or may not understand, or may have additional medical complexities or care or treatments that just add to the dynamics that have to be considered as we begin to discuss in-person services. When we have students with disabilities that have additional medical or behavioral conditions, they run a full range. They could be autoimmune conditions, they could be respiratory disabilities. There are students that are connected to oxygen out of need every day. They receive full-time care services, or we have students on the autism spectrum or with intellectual disabilities that may have difficulty conceptualizing what's happening or how to maintain their own safety, or may have some behavioral concerns that add to the complexity of how to manage in-person services. So the schools right now are really thinking of how should we be planning for these unique circumstances for our students with disabilities that tend to be our most vulnerable, as well as for our staff that work with them. For students with more complex medical or behavioral needs, they often require close proximity of staff. It often requires some form of physical touch, so social distancing is impossible. It ranges from regular changing, hand holding, physical prompting, feeding, just to name a few. As previously mentioned in the very strong foundation at the opening of this episode, they have a higher increased staff to student ratio. The more complex the students, the more adults work with them, and the more shared adults work with them. So we have occupational therapists, physical therapists, speech and language therapists, nursing services that rotate among a very large caseload to make sure we meet the needs of students throughout the day. So it brings to the front of our mind, what are the additional precautions that school systems need to consider in their health and safety plans for these type of scenarios? What are the recommendations for schools to support staff that work with multiple students in multiple buildings or even in multiple districts that we can ensure we put into place to reduce the spread of the virus among communities? Are there alternative processes or procedures that are recommended when working with students that cannot practice social distancing? Students with disabilities with more complex needs also often have a variety of resources that travel with them to and from school, whether it is equipment that they need to use, whether it's preferred instructional items, whether it's particular meals that need to travel, or assistive technology. So with the resources going from home to school and being transported, what are the additional precautions or procedures we should put into place to maintain safety for both environments? The paraprofessionals and the professionals that work with these students are often in situations where bodily fluid may be exchanged either through daily instructional practices or service requirements. So we are trying to plan and gather information from this panel of experts of what are some of the recommended processes or procedures in addition to what is there for the professionals or paraprofessionals that work with these students when we know bodily fluids may be exchanged and socially distancing is not possible. And then when it is exchanged, what are the additional sanitation processes or things we may want to put into place, just knowing that often is just part of the job that we do. These students require additional transportation considerations. They're transported in a smaller vehicle, and there's staff required for safe transportation on these vehicles as well. So are there things we need to consider, or are there recommendations in this area? As mentioned, there are students that are medically fragile. Are there particular conditions that would prohibit or be recommended that students not attend school? We are also in agreement that there is nothing that can replicate in person the personal relationships between teachers and students. It's imperative. So as a last resort, are there things we need to consider, certain circumstances we need to consider where it may not be the preference for the students to attend school? And if that's the case, what are the additional processes and procedures for educators who may need to go into the homes? In addition to what are the necessary additional precautions that should be taken that we as educational experts don't know, right? So we're depending on the medical experts. We can plan for the educational adjustments, the instructional adjustments, the potential increase of mental health needs, and we are doing so. But we certainly are seeking the advice of the medical field so we can do this well. We are extremely motivated and eager to have our students back. We miss them, and we know they need to be in front of us, and we're eager, but they are the most vulnerable students. We're very passionate about them, and we just want to make sure that we do it well to ensure that their safety, our staff safety, and their family safety as they go from home to school and back and forth. So we do welcome this opportunity, and thank you for the advice you're willing to provide to us.
Thank you so much, Carol. So Rylan, let's turn to you right now. What do schools, parents, and support staff need to know about youth and families' rights to access services?
Yeah, thank you. This is a rich conversation, and I feel the need to take a deep breath as thinking about really taking a moment and hearing from a family perspective and really taking in the information about the risk, about the real challenges and the factors that schools are thinking of, and then really returning to that care map and think about how do we engage in communities and services in the safest way possible. The real strength here is that we're coming to these conversations from a place of established relationships and established rights. It's been encouraging to see the individual team decisions that are built off of the Individuals with Disabilities Education Act and the need to make really concrete plans for each student, knowing that, as was just so clearly articulated, the needs for safety, the accommodations, the plans, and even the settings will be different in each situation. I think we're starting to hear about the tension of real large planning and the unknowns and really the ever-changing environment. Our national data is deeply troubling. The awareness that we're not really at full data about the risk to kids because we protected our population of children in America by keeping them home this spring. And so what comes next is deeply worrying for many families. I do think that I'm encouraged by a couple of things. That families have the experience of working with teams and planning effectively for different scenarios. One of the things that is a benefit of raising kids with disabilities is that you are often resilient and flexible. My family often talks about my love for a plan A through Z, and I think COVID really articulates how critical that will be. It may be a case that when we're thinking about returning to school for an individual student and that being the ideal environment, that we do start the school year that way, but might have to return to an equivalent setting when the flu season surges or other factors change in a community. So thinking about those pieces in planning. I will also say, and the care map really articulated it, that when we think about the services needed to support a child with a disability and a complex healthcare need, that while many of those related services, those speech therapies, the occupational therapies, are part of school plans, in many cases they're also part of medical system plans and community pieces. That's a complexity that I think will be a challenge for both schools and families, because when we think about the number of contacts, in some cases we're doubling up. So, I've started to have conversations with some school systems that are thinking about, is that an opportunity? Can we provide that free and appropriate public education and those related services by working with the medical team for that OT? So instead of being exposed to two different occupational therapists, we work on both the school goals and the home goals with one therapist that's contracted. So really thinking outside of the box, using all of our levers and all of our funding mechanisms. The additional funds that came to states for Medicaid provides possibly a window of opportunity for some of those relationships. I also think that the real fundamental challenges that have been articulated so clearly in everyone's conversation is that need for students to be parts of learning communities and to have that experience, that it is not just about making skills gains and building our educational environment. It's really about what we've all known and learned in a society over the last 30 years. We're celebrating this month the 30th anniversary of the Americans with Disabilities Act. And we know that individuals with disabilities have our best lives when we are fully integrated into the community. So it's deeply worrisome to think about in a scenario where COVID creates segregation for students with disabilities. I loved the frame about the opportunity to really build that social understanding and citizenship as school communities come together to create safe environments for all of their students. When I think about what the learning is from COVID, it's not just the desperate learning we need to do in our public health system, but think about children today that are empowered to keep their school setting safe for their friends who are students with healthcare needs and disabilities. And if that lesson is part of what you're learning in kindergarten now, the pay it forward for what that means for our greater access to society and full inclusion for the future is critical. I'm aware that this is going to be bumpy, and I think we should acknowledge that. There's going to be tension and concern. Some of the tension, the concern is based on fear. Families are scared. It's very scary. I am deeply troubled by the reality that my young adult daughter will be returning to a college campus with a medical complexity. And I say over and over again that I believe in the dignity of risk, but that does not tap down my fear. And so those tensions around fear, also the reality that this is hard. This is new learning. These are new accommodations, and not everything will be perfect. Will create points of tension for schools, for individual IEP teams, and for classroom environments. I think we can all use the existing legislation and rights and experiences we have to work through that and really be open to that this is an evolving public health emergency and the needs are going to evolve. And so we're going to come to it with a plan. We're going to work on, sort of that quality improvement. We're going to go back and say, what do we need to do differently? What's working? What's not working? And what are the risks that we need to make changes for different students? I think there's a lot of pieces and parts, but I do want to help families feel encouraged that it's possible. And I want to encourage families and schools and medical practitioners, because I've heard a lot recently of, I don't know yet. And some families are receiving that as, they're not listening to solving my problem. I think we all need to take a collective breath and say, I don't know yet means I don't know yet, but there's an opportunity in solving really complicated problems that will help us all move forward for the future. I think some of those practices that were referred to around hygiene and managing bodily fluids, that matters now, but those are lessons learned that are going to serve our school communities forever. So there's lots to think about, but lots of opportunity for great interactive plans.
Such wonderful comments and presentations by both Carol and Rylan. I feel like you've really captured sort of both the complexity, the nuance, and also just a lot of the exciting opportunities that may arise from building better. Let's turn now to Kate, and I'd love to hear your perspective and talk about the importance of continuity of care, how therapies and services can be delivered safely in the context of young children in particular.
Thanks, Dr. Jan, and to everyone for having me today. I think this is such an important and vibrant discussion, and I love the charges that have been laid and the challenges, but also the optimism of how we can craft some solutions moving forward. So I'd like to raise a couple of considerations regarding the populations I care for as a developmental behavioral pediatrician. So I work with a lot of children with different developmental conditions such as autism spectrum disorder, ADHD, learning disabilities, and many others. And we know that, as has been stated and was depicted so beautifully in the slide you presented, Dr. Jan, these children with developmental conditions rely on so many services more heavily and rely on things like early intervention for young children or the school system to provide them not only with educational services, but also with things like speech language therapy, occupational, physical therapies, and behavioral supports, especially for kids with autism spectrum disorder and ADHD. And I will say that the closing of schools in the spring really hit our families very hard. Parents were asked to fill in as teachers and therapists. Sometimes they felt like they really received very infrequent and insufficient consultation from the professionals. And many of them were working themselves and trying to fill these dual roles as therapists, teachers, and parents. And for a lot of the families we saw, services were either discontinued or paused. Of course, many were moved to a virtual platform, but that also sometimes equated to decreases in terms of the frequency and intensity with which children received those services. And this is not just true for the families that I see, but also is reflected in a national survey. So an advocacy group called Parents Together did a survey this spring, I believe it was done in May, where they found that among school-age children who were receiving special education services, 4 in 10 families said that they were not receiving any support at all, and only 1 in 5 felt that their child was receiving all of the services that they were entitled to in their IEPs or individual education plans, which are, as Rylan was describing, are contractual and have a basis in the Individuals with Disabilities in Education Act. But even for students who were able to participate in some virtual sessions, there was a lot of variability in how those services were provided, with some schools holding synchronous video conferencing sessions or meetings that were more familiar to children in terms of their typical instruction routine, but others did more asynchronous, where they were just posting videos or assignments and having children turn in the work on their own schedule. These delivery methods may work better or less well for some children, but we know that children with special educational needs just might not be able to benefit from remote services in the same way as others have attested to. And a lot of that has to do with their ability to attend when they have attentional challenges, or, as was stated, just that need for physical contact or one-on-one prompting and therapies. And so as a result, a lot of the families that I care for are reporting that their children have lost skills or regressed in some areas. And so this really speaks to that importance of maintaining and continuing the therapeutic services for children with special educational needs. And as has been stated, this can take place through the early intervention system, through schools, but also through creative solutions by working with community agencies and even healthcare facilities to make sure that these children can continue to make their developmental and academic progress gains. I would really be remiss if I didn't mention that some of the setbacks and regressions that we noted are likely not uniform with respect to family race, ethnicity, and income. And part of this is related to the digital divide, whereby some families might not have access to or knowledge of technologic devices that are required for remote learning. For example, that same survey from Parents Together found that the lowest income families, those that made less than $25,000 a year, were 10 times more likely than wealthy families to say that their kids were doing little or no remote learning. And even for children who were able to access remote learning, the quality of that education was rated as worse among children who come from low income. This is also critical because families that are low income are also, we know that they're more likely to be essential workers, so may have had to continue working and thus would have been unavailable to supervise their children in that remote instruction. And families with other barriers, such as limited English proficiency, might have been unable to assist much with their children's instruction at all because of language barriers. I was able to participate in a phone call where families testified to the city of Philadelphia last week about some of the barriers that they faced, and some non-English speaking families reported that they were told to use Google Translate to just be able to understand the instructions and assignments that were provided for their children. So they were really challenged with being able to support them, even despite best intentions. And relatedly, there was a study completed by McKinsey that examined what they expect to be achievement loss, or what they called learning loss, that would persist in the case of ongoing school shutdowns. And while students overall are expected to have this learning loss and loss in their attainment of critical skills in math and reading, for example, we know they found that effect is most likely to negatively impact children from low-income Black and Hispanic backgrounds more, because these same populations are the least likely to receive high-quality instruction. All of these data really speak to the general population, but I can only imagine that for children with special educational needs, those from low-income Black and Hispanic backgrounds will have even more significant learning losses because of those gaps and how critical intensive educational services are for kids with special needs. I have a couple of ideas of ways that we can continue these services. I don't know if I have time now. I don't want to cut off the other speakers, but I can also address some of those ideas in the Q&A, but really being creative with solutions, and most importantly, recognizing I don't think there's going to be a one-size-fits-all approach that we can take with regards to this very heterogeneous population of kids with special educational and special healthcare needs. And it's really imperative that we abide by the IEP process, where families have the legal right to be included as team members in the planning for their child's education. And so families must be consulted and must be guided toward different options. And some, we can talk about it, but some might choose that for children who have higher healthcare needs, they may choose to continue only remote instruction. Some families may feel like their children just can't benefit at all from remote instruction and will opt, despite risks that may persist in the community, to continue to send their children. Or some families might feel that they can provide those supports and services and serve as service educators and therapy deliverers in the home, and may choose to keep their children home for those reasons. And I just want to mention another option, which is that some families may choose to forego some of these educational supports and therapies for the time being because of these concerns and risks. And so we should make sure they're aware that those children who miss service hours are entitled to things like compensatory education, where they can make up those hours when they feel like either viral spread is down, or perhaps someday if we have a vaccine and feel that we really are in control of this virus instead of this virus in control of us. And they may choose to opt to make up those service hours at a later time, or even to extend their education beyond age 21 where that's acceptable, as it is in Pennsylvania. And so I think it's imperative. The last point is that it's really important that we think about the children who are least likely to be able to benefit from remote instruction, such as those with special educational needs, or with those technologic barriers or family situations that preclude them from really participating in education, and perhaps prioritizing those when we consider who is safest to move back into the classroom. If we're doing sort of staggered schedules and things like that, we may need to prioritize children who can't access remote instruction as well. And by decreasing classroom sizes and things like that, we may be able to help mitigate viral spread as well.
Thank you so much, Kate, for a very, very wonderful presentation, and also just kind of bringing the importance of the recognition that there is unequal access to these different technologies and services, as well as informal supports that a family may have, and in terms of their ability to deliver these services, and sort of what those implications are on for those who have limited English proficiency or by different race. So I may come back to you for those points. Actually, our Q&A is starting to blow up. So let me start off bringing us back to some of the original questions about how we can keep our kids who may have difficulty socially isolating or socially distancing, I should say, and what are some of the alternatives or considerations to working with them, and sort of what are some of the solutions and guidelines, because I think that will help frame the discussions as we're talking about the potential solutions here. So again, Carol sort of described all these different scenarios in wonderful ways about sort of like all the different considerations for the different kinds of needs that students have. So maybe I'll start it off by asking Susan if you can address what are some of the alternatives we can consider.
So thanks for that question. And how I'll frame my response is, what are some of the possible opportunities to provide increased protection when we are bringing together students and therapists and teachers into a shared physical setting? I think we all acknowledge that if we were to try and put a safety bubble with only infection as a priority, then stay at home, isolate. We've demonstrated it works. But let's assume that's not what's best for our children, because I don't think it is. So one thing to remember is how this virus is transmitted, and that's through respiratory droplets. And so a fundamental part of our safety strategy, whether it's at home, in the community, or in a school setting, is to interrupt passage of a respiratory droplet from a person who has it to a person who doesn't. Obvious ways to do that are to try and pick out those people who have respiratory droplets and ask them to temporarily exclude themselves from these settings. And that's something we achieve through really good sick leave for parents or for teachers and therapists, so they won't have an incentive to work when vaguely ill or after exposure because they don't have the leave or economic supports to do so. And similarly, children and their families should be instructed on the critical importance of sitting out a week if you've just had an exposure, or if if a child has symptoms that may be suggestive of coronavirus. But when we bring people all together, we do need to know people can shed virus. We've been talking about this nationally for a while now, when they lack symptoms or very obvious symptoms. And in those cases, this idea of interrupting respiratory droplets is key. So doing that, the basic current public health principles are masks and space. So using a barrier on the person who might have the respiratory droplet, and that's infectious, and increasing space, knowing that respiratory droplets settle in about 6 feet. So in settings where perhaps one of two people can't tolerate wearing a facial protection, I think one opportunity is to explore how can the other individual wear facial protection. And that might be through a full traditional medical or surgical mask. But if we're talking about students who may have hearing disabilities, the young, or those with behavioral needs to see full facial expression, then opportunities to utilize things such as face shields may be important to consider. As always, it's a matter of balancing risk and reward. Face shields aren't quite as good as a mask, so it needs to be done with full transparency to all people in this setting. Clear barriers, plexiglass, lucite barriers that allow transmission of sound can serve as a substitute for space. When you want to have physical proximity for whatever reason, but aren't able or don't want to have a full 6 feet, a physical barrier such as what are now being called sneeze guards, but in between two people, can be used. That doesn't really work, though, in the scenarios Carol and Ryland described, where physical touch is necessary for behavioral support, for clinical support. And so we need to recognize that also is not going to work all the time. And then the last piece, and again, this is layering of pieces that can be used some of the time, but probably not all of the time in all settings. The last piece is thinking about moving virus from parts of the environment to inoculate oneself. And that's where issues of good environmental hygiene, wiping down surfaces frequently if they've been contaminated with bodily surfaces, frequent hand cleaning if you're a therapist or a teacher who is encountering saliva, let's say, as part of your care and interactions with one of your students. And then really trying to build a sense of discipline in learning how not to touch our face constantly. For me, it's almost like a nervous tick to like fiddle with my hair, and boy, is it challenging to break that. But I think that is part of breaking a transmission cycle. So those are some of the things that I think we can layer on as possible in a setting where teachers and therapists and students are coming together in shared physical space.
Thank you, Susan. And as Lauren Agoridis actually brought up in the Q&A, that the American Academy of Pediatrics did release guidelines on reopening schools, and it does go through sort of general principles of how to approach PPE and space and transportation and early childhood education and sort of considerations around spacing. I think the challenge about using the AAP guidelines is that it doesn't have a lot of details, and when you need to implement them in a particular school setting, that's where we find the challenges. And one of them being PPE, like should teachers be wearing, other than surgical masks, knowing that there is some increased transmission through like droplets through the eyes, or should we be considering other forms of PPE like goggles or gowns or N95s? And what are your thoughts around that?
I think that we do have to have an element of trust and comport ourselves. This is my personal opinion. Comport ourselves in a school setting like we do in a community setting, and have a degree of trust that all people are entering whatever community is, a school community, or even your local grocery store, with the best of intentions, with screening of oneself to make sure it's not an inappropriate time to enter that area, and to do so safely with a mask and clean hands. Saying that, I think that people who work with very young children who may, or children with behavioral practices who may have increased generation of saliva and respiratory secretions as just part of their condition, that's a time where you want to add a face shield to your PPE if you're a teacher, particularly if you're an older teacher or a teacher with underlying medical conditions. I think that's something to consider. I don't think we all need to go about the world, though, wearing the full armor of a medical professional. And I really hope we never come to a point where we have to seriously consider that.
Susan, this is Marcia, and I'm just jumping in with a follow-up question on that showed up in the chat. Someone wanted to know a little bit more about the effectiveness of face shields versus masks. And I think it's relevant for medically fragile students as well who cannot keep distance. So if you could just continue your conversation on that, I think people would appreciate a few more details.
Sure. No, this question of mask versus face shield is really kind of emerging in different parts of the country as something where there's very strong opinions about in people in my profession, in hospital epidemiologists and people involved in infection control. I don't think we have a lot of really hard data on this, but what we do know is that there's less occlusion of the margins of the face with a face shield. And therefore, there is a concern that there may be the capacity for respiratory droplets to come in through the sides and accidentally expose somebody in that space behind their respiratory, their face shield and their eyes, nose, or mouth mucous membranes. That said, it provides a fair amount of protection. We just can't quantitate it. So perhaps a way to finesse this would be to think about using it selectively, not all the time, but as something when you're in a situation where you really value that extra degree of communication that happens with full facial expression, or with a student who really, sitting and just interacting one-on-one rather than with a larger group, really would benefit from relief from a mask. Those are times to consider using it. Sadly, I think we're going to learn more. There's a natural experiment about to begin in September.
And Kate,
I would love.
Go ahead.
Great. This is Rylan, and I would just love to extend the conversation and really call to attention the great work that's happened in this natural experiment to build tools and resources to support families, clinicians, and schools in helping students be able to participate in wearing masks and PPE. There are some students for whom their disability will make this significantly more challenging. And so really thinking about what are the tools and resources, what are the social stories that are out there that can build this skill. And also this time now before schools reopen as a chance to try out some of the options that are available in terms of mask for an individual student. We know that for some students, the texture, how it's attached to their face or their ears, the innovations that are now available in terms of hooking it to a baseball cap can really get compliance in a different place, and really thinking about helping people navigate that process as school communities come forward and start to resume being in place really builds those relationships and empowers us all to be in a classroom setting together. I also noticed in the Q&A really that call out again about students with hearing disabilities or for whom facial expressions are really critically important. So the variations in mask that use that clear vinyl to give some access to that. So I think as families are navigating this, we're going to learn together about what some secrets to success are. I frankly am looking forward to seeing some really darn cute unicorn and heart mask coming forward in the back to school space. I think really helping, empowering folks to get access. Also acknowledging the real challenge for some of the more formal medical type equipment, that there's still a challenge to get access to it in community settings, and that schools will be in the middle of that. So while face shields may be critically important to some schools and some educational settings, we'll need to work hard to support schools in getting what they need to support their students, because there continue to be challenges in just the distribution of those resources.
If I could just provide just a little bit of clarity regarding the clear face mask, just more of a missioning behind for our students that are deaf and hard of hearing or autism that really depend on the facial expressions. It's not a matter that they are the ones that need to wear the clear mask. It's a matter of everyone they interact with. So that means all of their peers, all of their teachers, all of the cafeteria staff, every administrator, everyone that they need to communicate with that require either lip reading or facial expressions are the ones that need to be in the clear masks, opposed to just the particular deaf and hard of hearing teacher. They need, visuals across the school day. And I'll stop. And the other piece is we do have some classrooms that have students with some significant medical needs that resemble a doctor setting, a hospital setting, the level of care of needs. And when you go into a doctor's office or a hospital setting, the protocols and the procedures and the equipment of those personnel are really different than are in an educator setting. I certainly don't expect that across the board, but when we have students that have full-time nurses with them or that have trachs or so on, real complex needs, are there differences? Are there unique things for those particular communities or environments we need to consider?
And just to jump in with another question that I think relates to this sharing of care plans between the medical team and the educational team, there are a number of questions in the chat box about that. Can one of you speak to the best way that communication and sharing of care plans can be? And this might pertain particularly to those kids who need nebulizer treatments in the classroom.
And you want to take that?
Yeah, Carol, maybe do you want to jump in on that?
Say that again. I thought it was a medical question. Say it one more time. I'm sorry.
So there was two questions. One was like, what are some of the best ways for medical professionals and educators to maintain better coordination and contact? And there wasn't actually a medical question. That was the second part of that, which is specifically around nebulizers and for those children that may need them at school. So you don't have to take that second one.
I got it. So, you know, the best part and the strength of servicing students with disabilities is there is already a team established. There's already a team that meets. And for these particular students that have more intensive needs, it's a great opportunity to pull the medical provider into that team conversation as we're having the discussion of transitioning the students back to school so that there is one plan for this child, not multiple plans on how to transition. So to increase the communication, I think the mechanism is already in existence, and it's a matter of just including the right parties at the table as those conversations are having and representing it through the individual education plan.
Susan, did you want to try to take on the nebulizer question?
I will do my very best. Nebulizers are a little bit of a hot button topic in medical settings because they intentionally create very, very fine particles referred to as aerosols. And those aerosols can both contain a very small amount of virus as well as travel long distances. And so there's concern that with traditional nebulized treatments, there is a risk of broader spread of coronavirus if a child is actively infected at the time they receive a nebulizer treatment. Not knowing how all the different options to administer respiratory treatments, I don't know exactly what other options besides use of an MDI spacer might be something to consider in a classroom setting. But that's certainly what we have strongly encouraged our clinical providers to use routinely now, and to reserve use of a nebulizer for a child with coronavirus only when it's a very controlled clinical setting to reduce that risk of potential exposure to a virus-containing aerosol.
And if I may just kind of add on to both of your comments, in the end, this needs to be a very close conversation, right, between the school nurses and the child's treating physicians. And I think this, to just kind of speak upon sort of the importance of continued communication and sort of really knowing who that school nurse is from the standpoint of the provider, and having that school nurse be able to easily access that particular provider, I think, is also really key. Where our traditional forms of communication have been fax, telephone. It's terrible. It's antiquated. And it takes an hour, 2 hours, when you're lucky, for a response back, if not a few days. And so the increased access then means that we need to sort of have, you know, what are the different ways electronically that we can sort of communicate, whether or not that's by email or by, having, a direct line. But I think what that means that from a policy standpoint, from the standpoint of the providers who take care of these children, is that being able to sort of know how much time that's spent, because this will clearly increase the amount of time that is spent collaborating with schools and teachers, which is exactly what you need to do, but being able to have mechanisms to continue that compensation in some ways to be able to make sure that you can continue doing so. And thankfully, during the emergency proclamations from the different governors, it's allowed us to be able to continue doing that through telemedicine and telephone services. But I do worry about what the richness of that communication and what that will look like once those emergency if telemedicine and interprofessional services are no longer supported around the country. Marcia, do we want to, because we have 10 minutes left, do we want to go to the other questions in the Q&A?
Yes, there were some very specific ones I think that can be easily answered, but everyone will be interested in terms of doing temperature screenings for staff and children before entering school. And Susan, I'm afraid a lot of these questions will fall on you for these specific ones. So if you could address that one.
Sure. While there are some states who are mandating temperature screenings before entry into some sort of a shared facility, what we've learned from other institutions over the past 3 months is that's actually not a very good strategy to identify people who don't know that they're sick. Temperature screening has, at several of our Philadelphia institutions, picked up less than a handful of people that had fevers. And of those people, I think I know of one person who had coronavirus and hadn't been previously diagnosed. And that's out of tens, if not hundreds of thousands of temperature screens. What temperature screens will do, though, is create a big log jam of people, oftentimes as people await getting their temp checked. And as somebody who seems to be spending so much of her time talking about social distancing, I'm much more afraid of the social clustering that happens while waiting for a temp screen than I am of not having a temperature screen. So I guess the punchline is you have to follow your local regulations, but I would not advocate for introducing a temperature screen into your system unless it's required.
Thank you. A number of questions also reference parents who would make their own personal decision not to send their child to school and not trusting a school system that even puts in many of these safety care plans in place. And the comparability of virtual or teleintervention versus in person, and how we can use that effectively and create an equal quality of care. Carol, I know you'll be facing this situation in Pennsylvania, and maybe you could speak to this.
Sure. So each local education agency, each school district will have to establish their own process to support the fluid attendance of students based on needs. There has been recommendations from the state, multiple states, to be flexible and have multiple plans in place to support this situation, knowing it could be very fluid for all, and it could be very fluid for particular staff with needs or particular students with needs. So districts are in the situation right now trying to be creative and to plan this process moving forward. But ultimately, it does come down to each local educational agency and how they develop their plan.
And Carol, you will see there's a number of questions to you that speak to transparency about what those policies are by a Department of Education for children with disabilities. What is the plan for communication to families and others about what the plans are? And is there any family involvement in creating those plans right now?
Okay, so all of the Pennsylvania Department of Educational guidance is on our website. So you could go on to the PDE website, look under COVID searches, and you could find all of the guidance that the Pennsylvania Department of Education has put out. It's front-facing, it's very public. In addition, any additional guidance that the Bureau of Special Education has put out in reference to students with disabilities is on the Bureau of Special Education page, which is also forward-fronting and accessible to everyone. PDE is in the process of developing a guidance tool. There's multiple different guidance coming out from medical areas, providing some really good considerations for school districts, and we firmly feel that that is not our area of expertise, and we're depending on the medical community to provide some insight. But PDE is providing another guidance tool for districts as they're planning opening to consider the safe and healthy plans in every capacity, as well as additional mental health supports that might be needed, or wellness for staff and students, instructional planning, as well as Dr. Wallace alluded to, really looking at what we learned from this experience on this very quick pivot. There's a very quick pivot globally to go from brick and mortar in-person instruction to remote, and it really exposed a lot of things that we can build upon. I mean, we could discuss about the inequities, or we could discuss what we learned and how we plan to move forward. And we certainly have learned a lot through this process, and part of our overarching plan is everything we need to do to move forward to improve the equities for all students. So all that information is up on the PDE website, and I am seeing local education agencies surveying their communities and their parents. I've seen multiple districts ask for input from their families as they're doing these plans. These plans the health and safety plans need to be board approved. So they are in the process over the end of June, July, and August, presenting the plan to their school boards. So it's a great opportunity for parents to become even more involved in their school district and attend the school board meeting to see the plan. And many of them are virtual now. So it's a lot more convenient to attend. And then many local education agencies are providing some parent meetings to educate them. So I am seeing a very active planning process and starting the beginning communication process with families as the plans are being developed. Simultaneously, in the month of August, I did see a question specific related to special education. I will be partnering with the Peel Center, which is the Parent Advocacy Center across the Commonwealth, to do a presentation for parents of students with disabilities about the opening of school. And the Bureau communicates to our variety of stakeholder groups. We communicate to the state task force, who then communicates down to the local task force. We communicate to HUNE, the ARC, a variety of advisory groups who also do an excellent job of communicating to families. If there are additional concerns that parents may have, we have an RA account, an email account that parents can submit questions to that we are very quick to respond. So there's a lot of unknowns. As you can see, we're trying to navigate, but I do agree that communication to families and including them in the decision-making process is imperative. And schools, as they are developing their plans, are starting to develop that active role of ensuring that parents are included in the process and being informed.
Carol, for those on the broadcast who don't live in Pennsylvania state, is that process pretty similar in other states, or does it vary significantly state by state? And what should either sort of the stakeholders that are on this group sort of be doing in other areas? And perhaps, Rylan, you can answer this as well.
Sure. I participate in a lot of state calls frequently. We've been working collaboratively through the national leadership of NASD and OSEP to try to ensure that we are all working the same direction. So I can attest that all of my colleagues at the state level are having the same conversations at their state level. There might be a couple of nuances, but each state has their own parent advocacy PTI that is a resource to all families. all states have a special education advisory council that can be a support to families or help in decision making. And all states have a particular either complaint system or communication system to reach their state if they have individual concerns. I would just suggest that they either reach out to their parent advocacy PTI, or they search their state website for the communication to their direct Bureau of Special Education.
Yeah, I would add a couple of things. I think that it can become overwhelming when families are trying to navigate all of the guidance documents that are out there. I think it's fair for families to gather the information that's relevant to them. You know, certainly the Centers for Disease Control provided some overall guidance that is being used by schools around the country. So looking at that, the American Academy of Pediatrics provided some guidance this last week that was shared in the chat box. And then, as was mentioned, most states that are making guidance documents are posting them on their website. So really looking about what's informing the decision that's impacting your individual family and where you live. And then really thinking from a perspective of what questions does that leave for you and what are the individual factors that are going to be specific to your child. And bringing that back to the table can really help inform your local school community, but also it's really a factor where we're all learning together and can certainly inform what a state is doing. And then we're seeing a national conversation. I was involved in conversations yesterday with Senate offices that are looking at advocating for adding $11 billion to special education funding to support the real needs that are going to be felt by schools around the country. Really thinking about all the levels that are involved, how to get the information that's connected to your individual family and sharing that back in the way that makes sense. The other piece that was referenced is the reality that individual families will make decisions about not returning to school. I think it's critical when we think about that we remember that this is, I hope, and Dr. Fauci keeps telling me, a temporary public health emergency. And at some point, we will all get to reopen. So if we're making a decision about an alternative setting for a student, we should be planning for the return to a school community and really being mindful and intentional about keeping those connections going. So we all need those connections personally. We need our supports and our peers, and we need those relationships. So it cannot be seen as an either or. Instead, it needs to be seen as a moment in time, and we're planning for a post-vaccine world that I'm cheering the scientists for every day.
Yeah, I'd like to jump in and just reiterate that. I mean, that we are thinking about individualized education plans, and so thinking about this on an individual basis should also be considering this on an ongoing basis. And the risk-benefit calculation may change, and it's important to listen to families who confer with child's teachers, therapists, medical professionals in making those calculations. I think all families, we know that they have their child's best interests in heart, and they know the importance of education and therapies for their children. But if they are truly concerned about an individual child's viral risk, it probably has something to do with some additional medical complexity. And it's important to remember that so many children who have developmental needs and special education needs often have these co-occurring medical conditions. The risk is much higher that a child with a developmental condition may also have things like prematurity, a genetic condition that puts them at risk, and or even a more common medical condition like asthma or eczema even. And so what does that confer in terms of their likelihood, as was noted by Dr. Coffin right in the beginning, about what that means for them contracting the virus and then having more severe illness as a result of it.
If I can jump in real quickly, just to follow up on Kate's comment. I'd just like to share what we think we're learning from a pediatric medical standpoint, which is all chronic conditions are not created equal. And we're seeing many children who have asthma that is relatively well controlled ate through a coronavirus infection with no complications. So I just want to make sure that we share with everybody on the call that even a common and potentially very severe chronic condition such as asthma does not confer substantial risk to all children with that condition. It's really about how well controlled it is that differentiates children who will have more versus less risk if they were infected.
Thank you, Susan. Amazingly, we are now at 11:15, and so I feel like we can continue this discussion for hours. I think some of the lessons taken away from this panel are that clearly the partnership between medical and educational professionals and parents needs to be tight, and that most of these plans, because it's not that all children with special healthcare needs are the same, all of these plans will need to be individualized, and certainly there will need to be substantial supports for educational environments, particularly in terms of funding, because we clearly need quite a bit more staff and equipment to be able to make sure that these children get the accommodations that they need for either remote or in-person learning. So I wanted to thank everyone who joined us today on the panel, as well as all the, I think, 450 attendees of this virtual event. It's been a terrific conversation. I hope that we can help inform continued support for children with disabilities and special healthcare needs and their families as we navigate this pandemic together. So a recording of this event. And again, I want to thank also Children's Hospital Philadelphia PolicyLab for putting this together and pulling together a wonderful set of experts, as well as this continued series. So thank you for providing this forum for us. A recording of this event will be posted on PolicyLab's website tomorrow at policylab.chop.edu. Thank you, everyone, and have a good rest of the morning and day.